Thank you very much, Nick, for inviting me to come and talk here. When you gave me this title, I wasn't sure if you were referring to myself, because that's how you often will describe me. But as Tusha has alluded to earlier, I think this is an important topic, and really I think before I go into it, I just want to show you my disclosures relevant to this. So what I'd like to do is to go through the evidence and an overview really of pacing. And firstly, is there really an indication in these patients? We can have a look at some of the evidence in terms of the studies that have been done and how they've been translated into guidelines. And then we'll look at if a pacemaker is required, how it should be delivered. And also we'll talk about some of the pitfalls potentially for pacing potentially in young patients. So I think the previous speakers have done an excellent job really and have given my talk mostly, but I think when we're talking about the general principles of somebody with syncope, we have to really look at risk-based stratification, and clearly we want to look at these patients to make sure there's no underlying anatomical substrate for why we may implant a device. And we need to be aware that although bradycardia may be a frequent mechanism, it doesn't necessarily mean that pacing will actually be effective in these patients, especially if there is coexisting hypotension. And I think what's been really important, as Professor Sheldon spoke about in his talk, is that in these patients, very frequently, there will be a reduction in their symptoms. So in over 50% of these patients, they may not have a further reduction in terms of syncope. And this is really very important because this means that firstly, if you're going to give a patient a treatment, especially a pacemaker in a young patient, it's possible their symptoms would actually abate without any treatment. And also the importance of this is if we look then at the evidence, the studies that have examined pacing, again, if you have a treatment where you have no control group and you have something where there's a spontaneous decrease, then clearly any evidence shown from observational studies may be flawed by the fact that there is no control group in these patients. So in terms of pacemaker implantation, clearly in patients that are going to be assessed for this, there has to be an effective element whereby there's going to be an electrical problem. So asystole has to be the dominant feature if we're talking about reflex syncope. And as Tusha said in his previous talk, it's very important that we establish the relationship between the symptoms and bradycardia, and that's very, very clear to direct our treatment. And again, the efficacy of pacing will depend on the clinical setting. So this is taken from the ESC guidelines, which were updated in 2018. As you can see, in patients who are considered for pacing, the effectiveness of pacing really is going to be established whether or not there is bradycardia in the absence of hypertension, where pacing may be effective, whereas in those patients where there's a mixed effect with bradycardia and a hypertension, or predominantly a hypertensive mechanism, it's very unlikely pacing is going to be helpful in this patient group. So what is the evidence for pacing? And there is not a great deal of evidence in terms of randomized controlled trial, but if we look at pacing in terms of reflex syncope and documented asystole, so this study has been mentioned previously, the issue 3 trial, 77 patients. These are all patients over 40 years of age, and they had documentation on an ILR of either asystole lasting greater than 3 seconds with syncope or greater than 6 seconds without syncope. And these patients were given pacemakers and either turned on or off. And as you can see in the patients where the pacemaker was turned on, there appeared to be a significant reduction in the reoccurrence of syncope. However, there's a caveat in this, is if you had patients that had positive tilt testing, the benefit of pacing was much less in these patients. Also, if we look at the subgroup of the SUP2 study again, we can see in terms of patients with pacing in this type of patient group, again, we see significant reduction in terms of events. But again, this has to be realized that this is often a patient group where actually their symptoms may decrease over time. So again, if we look at indications for pacing, so according to the updated ESC criteria, currently there's a class 2A indication for pacing in these patients, usually with dual chamber pacing, when there's to reduce the recurrence of syncope, when there's clear documentation of ECT, of bradycardia in patients greater than 40 years. What about carotid sinus syncope? Again, very few randomized studies in this, but there are some reviews out there. This is a review of 601 paced and 305 unpaced patients, and again, trend to reduction in events with pacing. Again, a meta-analysis of 3 large studies showed a recurrence in syncope with pacing in this patient group. But it's interesting to note, and I think the previous speakers, I think Professor Sutton went through the guidelines, that the task force actually downgraded the indication for pacing for carotid sinus syncope from a class 1 indication to a class 2 indication, 2A indication. So I think this is probably the main area that there's a lot of discussion about, and this is patients with tilt-induced vasovagal syncope. And again, as we said earlier, really the rationale of pacemaker usage in these patients where there's a dominant cardioinhibitory reflex. So in patients where there's a dominant cardiovasodepressive reflex, it's unlikely that pacing is likely to help these patients. And again, the evidence in studies, again, from the SUPS-2 study suggesting is that there is a reduction in events. But if you actually look at the meta-analysis of all studies, you will actually see that there's a significant reduction in syncope in studies where there are no controls that didn't receive a pacemaker. However, if you look at control studies, the reduction in syncope is much less. So again, I think there's a divergence of opinion, but generally it would be suggested in patients that have tilt-induced vasovagal syncope that pacing should tend to be avoided. Adenosine-sensitive syncope. Does anybody have patients who have been diagnosed with adenosine-sensitive syncope? And hands up, anyone? Okay, this is something that's in the ESC guidelines, so this is felt to be a relatively new clinical entity. The patients with idiopathic AV block and a long history of syncope with no other cause for syncope, so normal electrical studies, EP studies. And these are patients when given adenosine, which will have significant episodes of sinus arrest of AV block. And again, there's some evidence in these patients that implanting the pacemaker would be useful. So clearly there are some studies and there is evidence to suggest that pacing may be useful, but I think we really do need further evidence to guide our treatment. So there is an ongoing study at the moment by Dr. Brignoli, which is looking at the effect of dual chamber pacing with a closed loop system. And this will be a multi-center randomized double-blinded trial in patients 40 years and older with frequent vasovagal syncope. And this will compare the effect of a dual chamber pacemaker, either programmed actively or programmed in the placebo manner audio mode with a 2-year follow-up, and we hope to see some results in October 2019. So how do we put this all together in terms of the evidence? So these are the ESC guidelines. So who should be considered for a pacemaker? So if we look at the guidelines, what suggests that cardiac pacing should be considered in the patients, as we said from the issue 3 trial, those patients presenting in middle age or older age with documentation of asystole, either with greater than 3 seconds of asystole and syncope, or greater than 6 seconds due to sinus arrest. So this is a class 2 indication. Again, pacing should be considered. Again, a class 2 indication in patients with carotid sinus syndrome, again, where there's a predominantly cardioinhibitory response. And we have then class 2B indication, so a less strong indication in these patients. So in patients with tilt-induced asystolic episodes, greater than 40 years of age, one can consider a pacemaker. And again, patients with adenosine-sensitive syncope, if you ever see it or diagnose it, pacing may be helpful. But clearly, pacing does not seem to be helpful or indicated in patients where there's absence of a documented cardioinhibitory reflex. So these are patients who may have syncope, but predominantly vasodepressive type syncope. Pacing is unlikely to be helpful in these patients. So we can create a pathway, and again, this is taken from the 2018 guidelines. So if we take our patient here, if we have a patient with severe, recurrent, unpredictable syncopal episodes over 40 years of age, clearly if they don't have such symptoms, patient is not indicated. The suggestion in these patients, we should consider performing carotid sinus massage and tilt table testing. And if the tilt table test is, if the carotid sinus massage is positive and the tilt table test is negative, these are patients that should be considered for a dual chamber pacemaker implantation. If they also have tilt positive, they should also be considered for medication to counteract hypertensive susceptibility. If this is negative, then it's suggested that you should go on, and if you have a patient as asystole, when you tilt the patient, consider implanting a dual chamber pacemaker. But if they don't have those symptoms, then this is, as where Tusha alluded to earlier, the use of an ILR may be useful in these patients. And if these patients are implanted with an ILR, And then you document significant bradycardia asystole, usually implant a dual chamber pacemaker. And if there is no correlation with symptoms, pacing is clearly not indicated. So if we are to pace patients, how should we do it? What sort of pacing mode should be used? Well, generally dual chamber pacing has been used historically. The most commonly used algorithm that we use in patients who actually undergo pacemaker implantation is the use of a rate drop response. This is an algorithm that initiates rapid pacing when bradycardia is sensed, but sometimes this can be even too little and too late in these patients to prevent syncope. So some more recent evidence points towards the use of CLS, so the closed-loop stimulation algorithm. This is a proprietary algorithm from Biotronic, which measures local impedance within the right ventricle. And this may give you an idea of changes in contractility before bradycardia occurs. So this may allow you to treat the patient to allow pacing to be introduced at an earlier stage and prevent syncope. Very little data looking at different modes of delivery of pacing. There is some suggestion that dual chamber pacing is better than single chamber pacing. And as I said, that rate drop response is useful. And again, there is some ongoing data and some ongoing studies looking at the closed loop stimulation with the Brignoli study. What about leadless pacemakers, as these seem to be quite topical at present? So this is actually a UK paper recently published where actually micro was used in patients with vasovagal syncope. So a relatively small amount of patients, only 32 patients, mean age 37 years. And these are all patients, predominantly female, that had vasovagal syncope, diagnosed clinically and with Holter monitoring, tilt-table testing, with an average duration of symptoms of 8 years. And these patients were having fairly frequent episodes of syncope, 4 plus or minus 6 times a year. In all patients, a micro was implanted successfully. There's a low risk of complication. And with a relatively short follow-up, there seemed to be a significant reduction in events in these patients. But as I said, you have to really be very careful about studies which give patients pacemakers without a control arm, because it's quite possible that a lot of these patients would have improved anyway. So we've spoken about the potential indications. We've spoken about how we should deliver the therapy. What are the pitfalls? Well, I think the main thing that we have to be concerned about really is often in young patients implanting pacemakers, there may be complications further on down the line. And when Professor Sheldon gave his talk earlier and asked for a show of hands and asked whether or not syncope was actually a lethal phenomenon. And I think a lot of you said it wasn't, and a lot of you said it was. And I would put it forward to you that it's possible that if you treat a patient with a pacemaker, especially at a young age, then you may actually turn a non-lethal phenomenon into a lethal phenomenon. So to highlight this, I'll just show you an example of a case that we had about 18 months ago. So this is a 42-year-old male with a history of syncope. So this was 16, 17 years ago. He had repeated episodes of syncope. He underwent investigation. He underwent tilt-table testing and had an asystolic response to tilt-table testing. So he had a dual-chamber pacemaker inserted at the age of 26. And in fact, this did improve his symptoms. In fact, he had no further symptoms. But unfortunately, 16 years later then, started to become unwell with rigors and night sweats. And after about 6 months, he was finally diagnosed. He had echocardiography performed and blood cultures performed. And essentially, he had staph epidermidis growing in his blood cultures and vegetations on his echocardiogram. We'll show you the pictures in a moment. What's notable to say about this patient's initial implantation, it was said to be a difficult procedure, and there was one displacement and a further revision in this patient. So on the revision, a lot of loop was put into the leads to try to prevent further displacement. So the patient presented now with CIED endocarditis, initially treated with flucloxacillin and then vancomycin, and was referred for potential lead extraction. So this is echocardiogram of the patient. This is actually a transesophageal echocardiogram. And you can see here there is a pacemaker lead going across the tricuspid valve And you can see that there are echogenic masses attached to the valve in keeping with endocarditis in view of the blood culture results. And if you see now here with the color flow Doppler on, you can see this patient now has severe tricuspid regurgitation, either as a result of the leads going through the valve or more likely due to damage due to the valve due to tricuspid valve endocarditis. So this is an otherwise young, fit, healthy man with very young children. So it was decided that he needed lead extraction. It's clearly a class 1 indication, device infection, endocarditis. It was decided he should have this performed as a percutaneous approach. So this was done in the hybrid cath lab. And just to show you before we do this, so these are his leads. So as you can see, there is quite a lot of loop in these leads. You can see the atrial lead is a very long loop, and in fact, on imaging, this lead was actually adherent to the tricuspid valve. And you can see here with the ventricular lead, very large amount of loop, but in fact, this lead was virtually in contact with the pulmonary valve. So this is something that we generally don't like to see when removing leads if we have very large loops, because it can make it rather difficult. I'll just go back and forward again so we can play it, because it stopped looping. So this is the extraction. So this is a laser sheath, and you can see these leads are very, very tightly bound together. They're very tightly adherent here in the superior vena cava, having to use multiple laser sheaths and then mechanical cutting sheaths to try to remove these leads. And in fact, we got to the stage where we managed to remove the atrial lead, we managed to remove all the loops of the ventricular lead, and we thought, we'll just now go on and remove this lead. This should be relatively straightforward, when the anaesthetist said that the patient didn't have any blood pressure. And this image then is the pericardial drain that we've inserted because the patient has a large pericardial effusion. And this is the TOE image. This is the patient's heart somewhere over here. So the rest of this is all pericardium with blood and clot in it. So the patient has lost output and arrested shortly after this image. So the patient had the procedure performed in the hybrid lab. So the chest was already prepared for stenotomy and was opened very quickly. And patient had a tear in the right atrium. Also had a large laceration or a large tear in the superior vena cava and the brachiocephalic vein. The tricuspid valve had been destroyed, not from the extraction, but from the endocarditis itself, had very large vegetations on the valve, and that was debrided. The remaining pacemaker lead was removed from the SVC, and the SVC was repaired by patching. And the tricuspid valve was repaired, and an annuloplasty ring was placed. And this is at the end of the case, so this is about 8 hours after we'd started the procedure. As you can see here now, no lead material, actually a very nice result from the tricuspid repair. The patient, in fact, did very well, was discharged home after about a week, and we decided not to reimplant a pacemaker in this patient. Difficult decision. But in fact, if you look at data, and our data and other centers' data about patients that undergo lead extraction, about 15 to 20% of patients that undergo a lead extraction do not have a repeat pacemaker implantation. So you always have to re-question the need for the device. So in fact, in this patient, we decided to implant an implantable loop recorder to see then if the patient did have further symptoms and had asystole that would then merit pacing. But in fact, 18 months on, has had no further symptoms since then, has had a tilt test, which was positive, although it was a vasodepressor response with GTN. So I would argue in this patient that this turned what may have been a non-fatal condition into a very almost fatal condition. So just summarizing the last few slides, so I would say that as has been alluded to by the previous speakers, I think pacing can be offered to certain patients, but I would suggest that you try to avoid pacing in patients at all costs, really. So we can consider pacing in patients with reflex syncope, but it should really be the last choice. And it should be considered in highly selected patients, so really those patients over 40 years, probably mostly over 60 years, who have recurrent reflex syncope, and where they really are high risk to their having their syncopal event, and where there's little prodrome. I think there's a growing skepticism over the accuracy of tilt table testing, particularly in predicting the response to pacing. But really what does appear to be clear, I think what there is consensus of, is if tilt table testing does show that hypertension is the predominant response, then it's very unlikely that pacemaker is going to be useful. So I think we have to be aware that no therapy will completely prevent syncope in the long term. And even if we implant a pacemaker, decreasing the burden may be a reasonable goal. As the previous speakers have said, just because the fact that a decision to implant a pacemaker may be made and may be a reasonable one, you still have to question that, and you still have to speak to the patient and go over the pros and cons and the risks, especially in young patients where, 15, 20 years down the line, you may have problems. The patient may need lead extraction. And therefore, I think pacing should be limited to a highly selected proportion of patients affected by severe reflex syncope. But clearly, further research is warranted on this area. Thank you very much.